Hi, it's Dr. William, and thank you so much for joining me tonight. We are going to be talking tonight about breast implants. And before we get started, I just want to introduce myself. This is me here. My name is Carl William Schwartz. I'm a physician. I go by Dr. William because in Miami, people have a hard time saying my first name and my last name. So they just gave me my middle name. So I go by Dr. William. I'm a board-certified plastic surgeon. I grew up in Canada. I was born in Canada. Grew up in Vancouver. I went to my undergraduate there at University of British Columbia. I moved to London, Ontario to go to medical school, after which I moved to Detroit. I did my general surgery training. I also did a master's degree in genetics and did a couple of years in the lab doing basic science research when I did my genetics degree. And then I moved to North Carolina and completed a 3-year fellowship in plastic surgery at Duke University, and now I've been in Miami for about 8 years. Okay, so tonight we're talking about breast implants, and I started off with a little video on Instagram saying, can your implant track you? And obviously it was a tiny bit of tongue-in-cheek, but there is actually a little chip that's optional in some implants. We're going to talk about the implants later on. And this is an RFID, which is only the information that is given with this little chip. You can just scan on the outside, and then you can actually see the serial number of the implant and the implant model. So there are chips. We don't really use these in North America. They're used in Europe, and this little chip here can be sort of ordered ahead of time. We give everybody a card, which is their information, and usually that it really has the same information. So you don't need to have a fancy chip to know your implant serial numbers and size, but it is kind of a cool technology that they have. And you can see this is the one that I cut open for the little video, but you can see other ones. I have some that don't have them in. These don't have them in, and this does. You can see it's just a little thing in that situation. Is that camera working? Okay. So, all right, that's the information about the chip, but that's not why we're really here tonight. We're going to be talking about breast implants, and it's going to be pretty comprehensive. We're going to be talking about what are the different types of implants are there, what are the differences between those implants, where do those implants go, how do they get there, what are the risks of getting a breast implant. If you've followed me or ever watched one of my videos, you'll understand that I'm very much interested in talking about complications of plastic surgery. I think it's incredibly important before you do anything in surgery, anything in life essentially, to know what the risks and complications are. I always say that I'm kind of a worst case scenario person, so if I'm about to do something, I would like to know sort of what is the worst case scenario. I want to know kind of what the boundaries are, because I feel that if I can handle that, then I'm fine. I'm happy doing it. But if I can't, then that would make me second guess as to whether I wanted to do that or not. Most of the time, these worst case scenarios don't happen, but it's important, I think, to understand them. So we're going to be talking about the risks of a breast implant. We're essentially going to be coming down and saying, what is the right implant for me? This is just very similar to having a consultation with me in person if you're interested in having a breast implant. And so we go through all of these things. Tonight we'll be able to spend quite a bit of time and going through it. Now, if you know me, you also know that I talk a lot. So if you can get through all of those things that I just listed, you're going to get something really great. You're going to get this guide, which is the top 7 things to know before getting breast implants. It's a wonderful guide. It's totally free. And it's going to have all the information that I'm going through tonight. I basically wrote this guide as a companion to the talk tonight, so you don't have to write anything down if you don't want to. It's all contained in the guide, and there'll be a QR code at the end of the talk, and then you can download the guide for free. There'll be a QR code that you can just scan with your phone, or if you're watching it on your phone, there'll be a link in the description of the video. So it's really good. It's got a lot of great information. So, okay, let's start out and let's just talk about the two basic types of implants that are out there. Because this subject can get complicated very quickly. I'm going to try and keep it as simple as we can so that you walk away after watching tonight with some actually useful information that you know and understand and have. So when we're starting out, I've got a mountain of implants here. And so when we're starting out talking about implants, we're going to talk about the two basic types that they have. And those are, let me know if you can see all this okay, guys. Everything's good with my position? Okay. So there's two types of implants. There's a silicone gel implant, and there is a saline implant. This is not filled with any saline right now. This is just has some air in it, just so that you can see. But normally we don't put air in it. We only put saline in it, which is otherwise known as salt water. And the reason it's empty is because with the saline implant, there's a little tab here. We actually lift this little tab up. I'm going to show you here. We lift this little tab up during surgery, and we can insert into that little port a little nubbin, a little nipple, and it'll go in, and then we can actually fill the saline and fill up the implant. The outside of the implant is still made of silicone. So I know sometimes patients say they don't want to have silicone, they choose saline, but you have to know that if you're going to have a saline implant, it's still a silicone elastomer shell that's here. A silicone implant has the same silicone elastomer shell. It's a tiny bit different technology, but it's still a shell, except the silicone implant is filled with silicone. And these implants already come pre-filled from the factory. So this implant here is a 365 cc, so 365 cc's. Just for your own edification, a cup, like a measuring cup of fluid, is 250 cc's. So this is 365 cc's. That comes from the factory as that size. If I want a larger implant, then I have to get a totally new implant. If I want a smaller implant, I have to get a totally new implant. So these come pre-made sizes from the factory. They're sterile and we put them in. The saline, there is a little bit more variability in how much fluid we can place in the implant at your time of surgery. So this implant is a 400 cc implant, and what that means is that this implant shell, the dimensions of this shell, so the width of it, so the width of the shell, and also the projection, so how much is projecting or protruding in this way, it will reach its optimal dimensions at 400 cc's. That's what this shell is designed to hold, 400 cc's of saline water. There is some play with that. There's some variability, and each implant number is a little bit different, and some of the implant manufacturers also a little bit different. But in general, if you're looking at a 400 implant, then I could probably put 420 cc's in here. They'll give you the exact on the box, but in general, it would be about 420 cc's or 380 cc's. So there's a little bit of play when you're using a saline implant. Now, I say all of that, but I really rarely use a saline implant. And most implants now placed in the United States, and certainly in Europe, are all mostly silicone implants. We still offer saline implants because some patients are worried about having a silicone implant. You don't need to worry about having a silicone implant. These two are the same in terms of safety, but I don't argue with patients. If they want saline, then I'm happy to do that, and it's not really my job to say, hey, this is what you should do. I'm there to listen and help, but I will try to encourage the patient, which is a euphemism for kind of push them to try to get a silicone, because I think it is a better implant in general. It tends to look a little bit more natural, feel a little bit more natural. It has less rippling. The rippling, I'm going to show you a picture of that in a minute, but rippling is when you can see, usually you can see around the edges. We call it scalloping, or some rippling around the edges you can see with a saline more frequently than you can with a silicone. Still possible with silicone, but much, much, much less risk of seeing rippling, which typically happens on the outside of the breast, but can also happen towards the inside, which is quite devastating. It happens towards the inside. That's the cleavage. That's really the most valued area when we're talking about breast implants, so we don't want to have rippling in that area. So saline is available, but I think the silicone is a better implant. The final thing, this was taught to me by Dr. Hammond years ago, very knowledgeable surgeon in Michigan, and I visited him a few times. And you know, he was really the first to explain to me that a saline implant, in his opinion, and it's in my opinion too, and I've seen this many times now, that a saline implant, I think, is harder on your tissue. And this is filled with waters. You get like a little fluid wave. You don't even have to be like jogging to get that. I mean, just regular respiration, just breathing, and you can have little waves in there that I think will weigh more and take more of a toll on your tissue. I think that it leads to bottoming out sooner as well. So there's a lot of reasons why a silicone implant is a better implant than a saline implant. Now, this is rippling. Sometimes it's hard to see on this view rather than in real life. But here, if you look here, these are saline implants, and you can see this rippling where you see my mouse. See my mouse here on her breast, and right in the middle. So that's a problem with the silicone. Now, or saline rather. I want to talk about implant profile, because this always brings up a lot of confusion. So I'd like to clear that up here. So I'm going to get rid of that saline implant. This is just a regular silicone implant, and this is a full profile, so it's got as much projection as you can have. We would consider this a high profile projection. So let me just kind of draw that out for you and explain to you what the differences our profile are. Okay, so when we're looking at profile, we're considering to be the same width. Okay, so imagine that this is an implant here, and that's its width. So when I'm talking about the width, I'm talking about this. It's also, you'll hear of it talked about a base diameter. Surgeons, you'll see, measure the breast to get the breast width. So we're always talking about the width of the breast or the width of the implant. So if we're considering that the width of the implant is fixed, then if we look at different styles of implant, we'll see basically 4 pictures. And there's a low profile, a high profile, a moderate profile, and extra high profile. Now each manufacturer has different terms for them. Motiva, which we're going to be talking about tonight, that's the latest implant. This is really fascinating. These implants have only been on the market since September of last year, and these are really cool. And I really want to go into, and we're going to go into the detail. But this company, they call them mini, demi, and full. But just think of it, it's like Starbucks. You get a tall, grande, or venti. It's small, medium, and large. So kind of think of it as a low profile, moderate profile, high profile. Then there is something called an extra profile. And everyone there's Boost, there's Inspira, everyone has a different name. But the general understanding concept is that you have one that's low, one that's moderate, one that's high, and then one that's kind of extra high. And so what are the point of all of these, and what is actually going on here? So remember, for the same breast width, a low profile implant will have less volume. There won't be as much silicone in there, and the design of the shell is to be flatter. And so this low profile implant will give you a very natural look. In fact, this will, in my opinion, give you quite a flat breast. Now, some people want to have that, so it's totally fine. That's why we make that. I don't, but that's why all the implant manufacturers make the different profiles for different tastes in patients. I personally don't like the way a low profile implant looks in a breast. I don't particularly care for the moderate as either. So these two implants, have I ever used them? Yes, many times. Do I use them most commonly? No. Because in my opinion, these give you a very, very flat breast. And in my experience, patients wanting to have a breast augmentation are not looking at, aside from that subset of population of patients that want to look like that. So most commonly, I'm going to be sort of in the moderate to high area. That gives a more full breast. That gives a little bit more projection, a little bit more oomph, as I say. And so I tend to kind of stay more in that area because that's the look of the breast that I like, and it tends to be what the look of my patients like. Remember, you kind of create your own patient population, if you will. So I to tell patients, listen, I come up with a plan, I have a certain aesthetic eye, this is what I like. If you also share that, then yes, I'd be a good surgeon for you. If you prefer a different look, then I won't be the right surgeon for you, and there'll be another surgeon. So it's kind of a self-fulfilling prophecy where you hear surgeons say, well, all my patients like a really low profile natural look. Well, that's probably because he or she also enjoys that look, and so that's kind of how they cultivate their patients. For me, I tend to be here. I'm in Miami. Patients tend to want a fuller look in Miami, and so I tend to skew to the higher implant. What I don't use, but I do see it used reasonably often, is I don't use these extra high implants. And the reason I don't is because this projection here, remember, that's what's determining the profile, is really that amount of projection, and it's projecting from the chest wall. So a lot of patients think that an implant, if you have a high profile implant, we're talking about it coming up here, but that's not what it is at all. It's just going under your breast, and it's coming out in this direction. So with the high profile, you get a little bit more cleavage, you get a little bit more upper pole fullness, but that doesn't mean it's high on the breast. It's still centered under your breast. It's just projecting a little bit more, giving you a little bit more cleavage. So you think, oh, that sounds good. Well, I'd like more cleavage, I'd like more projection. Let me get an extra high implant. That's not what these implants were designed for. And they don't look good, in my opinion, in cosmetic patients. So for somebody that wants to have a breast augmentation because they want a larger, fuller, prettier, rounder breast, then I don't think an extra high is a solution. The extra high was developed not for the cosmetic population, it was developed for the breast reconstruction population. So the extra high implants were designed for patients who had breast cancer, and they had their their breast removed. They had a mastectomy, so the whole breast was removed, and so they need a higher projecting implant because they're starting without any breast tissue. When we're talking about a breast lift with implants or breast augmentation, we're talking about augmenting, adding to what the breast already has. And so there's a starting point. So if you use an extra high implant in that situation, you get kind of an unnatural, weird look. If you have a mastectomy, you need as much projection as you can because you're not starting with any breast. And the surprising thing that patients wouldn't have any way to know is when you do a mastectomy, because I used to do a lot of breast reconstruction when I first started my practice, and when I trained at Duke, we did a lot of breast reconstruction. And when you remove a breast, it's not just that the chest is flat, it's actually a little bit hollowed. And so you need that projection to overcome that loss of tissue. So that's the profile. It's a direction in this way, not up here. Okay. Now, implant shape. So we're just going through all the characteristics of an implant. So now we're going to talk about implant shape. Well, there are round implants. That's what these are. These are round. Is this better here? Juan or Oscar?
A little down. A little more down.
Okay. So this is a round implant. This is a circular implant. And so this implant here is what's called a anatomically shaped implant. This one looks more like a breast than this one. And this one here tends to give you a little bit more fullness in the upper pole of your breast. This one gives you less fullness in the upper pole and more in the bottom. This looks more like a natural breast and will give you a more natural result. That's a teardrop implant. This looks like a little teardrop. So I don't use these. And I'll tell you why. The reason is because implants tend to look more like a teardrop shape when you actually put them in the patient. So they have the effect of gravity. Now, with the new implant that I'm going to go into a lot of detail, there are a couple of different types of, they have a couple of different, I'm trying to read the size on this. Okay, 355, this is 325. So with this company, Motiva, they have two different styles. And we're going to get into this in a minute in more detail. But essentially, they have one that gives you a little bit fuller. So when I hold it up, it has a little bit more fullness here. This is a softer one, an ergonomics one, tends to look a little bit more natural. It looks a little bit more like this teardrop shaped implant, the anatomic implant. So even though this is a round implant, this can also look more natural than their other style implant, which has a little bit more fullness. I'm going to talk about these implants in detail later. But so why don't I use the teardrop implant? It looks beautiful and you'd think that would give you a nice result, and it can. The problem with a teardrop implant is that they can rotate. So you can have a breast implant that's in the correct position and then it can rotate inside the pocket. Now you don't have a very good looking breast. Ironically, you can have a round implant, it can turn, and it still looks, you wouldn't be able to tell the difference. And I know that sounds crazy, and I didn't believe it myself until I started operating and doing implant exchanges, and you'd come across someone every once in a while that had a smooth round implant, and it turned, but you didn't know because they looked good beforehand and were just exchanging their implant for a smaller or larger implant. But when you have the teardrop, the anatomical implant, this can rotate, and that creates a problem. So what did they do to prevent it from rotating? They made it textured. So with this texture, you see a close-up of that texture compared to an implant here that's smooth, okay? Two totally different things. This has a texturing. This has a feel to it. This is rough, whereas this one is smooth. So this one would be called smooth and round, and this one would be textured and anatomic. Now, the reason why they texture this is to prevent it from flipping on you. So this texturing causes it to stick, and it sticks to your chest, and it will prevent it from rotating. But there's been a problem in the past with texturing, and we're going to talk about that now when we look at these. So there's a smooth implant, there's a textured implant, and then there's a new entrant into the game, and that is a Motiva implant. And these are considered to be smooth implants But if you feel it, you would say, oh, well, that doesn't feel totally smooth. And you'd be right. It's considered by the FDA to be smooth because the texturing that's on here is very, very, very small. It's like 4 microns, which is, tiny. So you can perceive it with your fingers, but it's not nearly as textured as this one. And so in the 90s and the 2000s, we were using implants that were more textured to prevent this kind of movement. And the problem is that the textured implants, some of them, not this manufacturer, but some of those textured implants went on in a very small number of patients to develop a breast implant associated lymphoma, a cancer. It's not a very bad cancer, but who wants cancer at all? And so we realized that it was the texturing that was causing the implant to cause lymphoma. So those implants were taken off of the market. I don't use any textured implants, even though most of the data says yes, it was from this manufacturer and we've removed that implant from the market. So now it's not there. But most of us, or at least certainly for me, I don't use textured at all anymore. And so I've gone to the smooth implant. And I've used smooth for many, many, many years. But now with this is really exciting because it's smooth, but there is something there. And there are benefits to that, which we're gonna talk. But you'll hear people talk about a smooth implant, a textured implant. Sometimes they refer to this as a nano-textured implant. The FDA really considers it to be a smooth implant. Now, here's a knowledge nugget. I'm going to drop a few knowledge nuggets on you tonight, so stay tuned because these things are coming fast and random. So, you can move your arms after having a breast implant. And any breast surgery that you have, you should be gently moving your arms right away on the day of surgery. Not doing jumping jacks, but just gentle movements. And as you start to feel better, you can wash your hair and you can move your arms. It's an important point because if you don't, you can develop a frozen shoulder, which is absolutely no picnic. Okay, so we've talked about you can have a saline or silicone. They can be round, they can be anatomically shaped, they can be smooth, they can be textured. Now, where do the implants go? What's the location of the implants? And so you can go above the muscle, you can go below the muscle, you can go somewhere in between. So let me explain that to you because it's really quite a hot topic. So first of all, let's answer the question, what muscle are we even talking about when we're talking about above the muscle, below the muscle, somewhere in between? We're talking about the pectoralis major muscle. Those are the 2 big paired muscles on your chest. They're the largest muscle on your chest. The gym bros refer to them as the pecs. You go to the gym, there's a pec deck. So they're pecs. Well, we're talking about specifically the pectoralis major muscle. That's really the big one. There's a little one called the pec minor. It's under there, but we don't really mess with it. So we're talking about an implant being in relation to whether it's over the muscle or under the muscle. So let's break that down a little bit more clearly here. And if you look at this diagram that Manuel did, who's super talented, very nice. Now, here we go. Here we have a breast. So you're going to see your nipple, your areola. These pink here are is actually your breast tissue. The yellow is fat because your breast is made up of 2 things, the breast tissue and the fat. And so when we look at how the breast sits on the chest, it sits on top of the pec muscle. That's where I'm moving my mouse right now. So I'm going to take my mouse, start over here by the nipple areolar complex, and watch me move my mouse, and I come to this first red muscle right here. That's the pectoralis major muscle. Then there's the pec minor, which don't worry about it. Now this here with these little yellow circles, those are your ribs. And then under your ribs are your lungs. So your breast sits on top of the pec muscle, which sits on top of your ribs, which keeps everything closed, and your lungs are underneath. So if we just kind of blow that up and say, okay, well, now where can we put an implant? Well, we can put an implant a few places. We can put an implant right underneath your breast. Okay, that's called a subglandular position. That's your breast is a gland. We're going underneath. It's subglandular. So the implant is here. If you see my mouse here, the cursor, it's right underneath. Or we can place the implant underneath the muscle. But this is a general configuration. You have breast, you have muscle, you have chest. So let's look at it now. If we're putting the implant in a subglandular position, then that implant is going to be right here. That's a picture of the implant. It's right underneath the gland. So to show you what that is, if you imagine this here is our, I guess maybe better overhead for this. I'm swimming in implants here. Okay, so if we take, let's pretend this is your breast. Get rid of that. So let's pretend this is your breast tissue here. And then you could put the implant right underneath your breast. That's a subglandular location. Then what is underneath the breast implant is going to be your muscle. So you can have the implant under the breast. That's a subglandular. That's what I'm showing here on the screen. The implant's right under the breast. Or you can place your implant in, and that's just kind of a blow-up view of that, showing the implant underneath the breast above the muscle. That's a subglandular pocket. Or you can put the implant underneath the muscle. So this pink here is the muscle. So you can have the implant under the muscle and the breast sits on top of the muscle. Now, there is another location where you can place the implant. It's kind of in between. And we'll go through and we'll talk about why you would place an implant under a gland and why you'd place it under a muscle in a minute. But let me just clarify where these three pockets are. So just to recap, the first one, it's right underneath the breast gland. That's a subglandular. Second location, underneath the muscle. That's a pec muscle, so-called submuscular location. Then there's a third one, and that is a little kind of special place. And that is, if you imagine this as fascia, fascia is stuck to muscle. Muscle is really doesn't have much strength. It allows you to lift things, but in and of itself, it doesn't have much strength. So muscle is always covered by, and sometimes even totally wrapped by fascia. And the fascia is quite strong. And so what we can do, instead of placing the implant under the gland, instead of placing it under the muscle, we can actually place it under the fascia. So the implant is technically not under the muscle, but it's also not under the gland because there's another layer here, this pectoralis major fascia. So I tend to personally put an implant in under the fascia most commonly. There are reasons why we have to put the implant, or it's better to put the implant under the muscle in certain situations. So let's talk about that. Okay, let me go back here because I don't want to drop that knowledge nugget on you yet. So, okay, why would I put the implant underneath the gland? Why would I put it here? Well, it turns out it's actually a really good place to put an implant because it looks very nice, because that's where your breast is. We're just putting it under the breast. We're augmenting the breast. So it looks very nice. There's not very much pain for the recovery. And if anyone ever has a subglandular breast augmentation, they usually don't take any pain pills, and they're recovered very, very quickly. Within a couple of days, they feel fine. There are always the patients like, that was the easiest thing I ever did. I feel totally great. Because we're not really doing too much. We're very delicately going under the gland and putting the implant in. So it's a great spot, looks really good. But there are problems with it, and you can have a higher rate of capsular contracture. Now don't freak out, we're going to talk about capsular contracture in detail in a minute. But just understand for now that putting the implant underneath the gland has a little higher risk of capsular contracture. You can also see the implant more clearly. You could potentially see rippling more clearly. You could feel the implant easier. it kind of gives you more of a artificial look. If you used a very large, high-profile implant right under the gland in somebody that doesn't have a lot of tissue, they're very thin, you get those kind of round sort of balls on the chest. Now, for women, that's if you're doing someone who's really, really skinny and they don't have much test. They're not a good candidate to put it under the gland for those reasons, and they get that look. So in that situation, they really don't have much tissue. They don't really have much breast tissue. So if we put the implant right under the gland, they're going to see it, they're going to feel it, it's going to look really fake, and it's not going to look as nice in that situation as if we put it under the muscle. Under the muscle now, in someone who's very, very thin, will give them the coverage they need to get a more natural look because you have more tissue over the implant. You get a more natural look, you decrease the chance of seeing any rippling, and you decrease the chance of being able to really feel it or really see it. Obviously, it's kind of blunted. The analogy I use is if you're under your duvet cover, you can't really see who's under there very well compared to if you're on top of the duvet cover. So it's just providing, the pectoralis major muscle is providing a little bit more coverage. So it also has a lower capsular contracture rate, okay, to go under the muscle than it does to go just under the gland. So there are advantages to going under the muscle, and also in the right patient who's got good tissue quality, nice thick tissue, there's advantage of going right under the gland. But kind of a really cool happy medium is to go under the fascia. So if I can go under the fascia in patients, I do, because it's sort of like the best of both worlds. You get the benefits of having a little less risk of having a capsular contracture because you're protecting the implant from the breast. Whereas if you put the breast implant right under the breast tissue, you have a higher rate of capsular contracture. But it still gives you a nice appearance to the breast, just like a subglandular augmentation does. And it's also easier recovery because we're not lifting up the muscle. So there isn't one best location for an implant, in my opinion, and this is determined from patient to patient. And that's really what you have to sit down with your surgeon and say, okay, I understand there's 3 locations. I understand that there's a higher capsular contracture rate if I go under the gland. I understand there's lower under the muscle. But there's also problems going under the muscle, and that's something called animation. And what animation is it's movement, okay, like a cartoon animation. So what happens is when the implant is under the pec muscle, your body can contract the pec muscle. And when you do that and you squeeze your pec muscle, you can move the implant. And you can drive it towards the outside, you can drive it down, and it looks very odd or peculiar to see somebody squeeze their breasts, squeeze their pec muscle, and move their implants. Not everyone who has an implant underneath their muscle has that problem. There are things that we can do during surgery to try to mitigate that problem. But still, if you put the implant underneath the gland directly, it doesn't matter what the pec muscle is doing in terms of contraction, and the implant still looks good. So with the subfascial, you kind of get the best of both worlds. So I try to do that if I can. But talk to your surgeon. That needs to be a discussion that you have to determine what is the best location for you. There is no 100% right, 100% wrong, and it's got to be tailored to each patient. There's advantages and disadvantages, and those all need to be weighed on a patient-to-patient basis, and that's what I do. So, but I can tell you that it will make somebody's head explode if they really think that the only place you can put an implant is under the muscle. I would say that's what people most commonly think. And if I say, actually, I'm not going to go under the muscle, I recommend going under the fascia here, which is, I just really say subglandular because it's hard to sort of explain this concept of these 3 layers. So I just try and keep it simple and say, well, it's going to be under the gland, although not really, a little bit of barrier, but either subglandular or under the muscle. And so we have that discussion, And patients will say, when I say, well, we could put this under your gland rather than going under the muscle, you're not going to have problems with the implant moving with the muscle. It's going to be an easier recovery. It's a really pretty shape, and you're a good candidate because you have good tissue and you've got enough tissue to cover the implant. Then it's a good idea. And patients will be like, what? You got to put it under the muscle. And so what I've seen in my career in plastic surgery is there's a real time delay between what we're doing as surgeons and what patients sort of understand what we're doing. I think it's about a 5-year gap. So there was a period of time, if you go through the history of breast implants, they started to put the implant under the gland. And then there were a lot of problems because we're talking about now in the 1960s, 1970s. And the implants back then were very poor technology. So there were a lot of problems. As technology started to get better, it's allowed us to be able to put more implants under the gland and still keep our complications low. But patients still think most of the time when I talk to them that you got to go under the muscle because we told you that. We were the ones that told you. So we said, hey, we'd put it under the gland in the 60s and 70s. Then we realized, well, that's a problem. So they started to go under the muscle. There was a lot of different problems with that. And then they started to say, oh, listen, we have new techniques and new technology. We can start to go under the gland, and you can still do that safely and get a nice result with low complications. But I think patients are still kind of here under the gland, and it's like, you told us it's supposed to be under the muscle. So there's a little bit of change there. So understand that. Talk to your surgeon about that. Okay. Knowledge nugget. Your friend's implant size is not your implant size. And size is a huge topic, and I'm about to boldly wade into it. So here's a little question for you. Who has the larger implant? In this situation, that patient has a 425, this patient has a 600. To me, the 425 looks bigger than the 600. So the whole point is, it doesn't matter what your friend's implant size is. In fact, I'm going to say this, it doesn't even matter what the number of the implant is. What? Yes, that's my philosophy for sizing. We're about to wade in there. Okay. So, before we're going to get into complications, I'm just going to take a brief moment to talk about size. And actually, to be honest with you, I wasn't going to talk about it, but I'm going to talk about it right now. So, I'm old, and I do things the way I was trained. So, I use a sizer, and I would say probably most surgeons nowadays don't use a sizer, and they do a lot of measurements, and they determine the size implant before they go to the operating room. And I've done that before. I did that for quite a few years. And I used to take a lot of detailed measurements and a lot of calculations and determine what the implant I would use in that patient after discussing it and getting to know what the patient wants. And we come up with a sort of number of an implant. And the difficulty is that you can kind of become too married to that implant number before you go in, and then you're trying to sort of make that number work. And I just found that to be frustrating and honestly, in my opinion, kind of silly. I was like, I don't need to be an expert in predicting the exact number that every patient should get. So because there's so much variability when you go to operate on the tissue. Every single person's tissue is different. So what I do now is actually a very simple way of doing size, but it terrifies patients. And I realize that, and I tell patients that. And so what I do is when I go into surgery and I'm operating, I make an incision underneath the breast. We can make fairly small incisions now because we put all of our implants in with a funnel. This is what's called a Keller funnel. And it's lined with a very slippery material. It gets very slippery when wet. This is actually some type of an algae compound derivative that is really, really slippery. So we get this wet, we trim it to the appropriate size to accommodate the implant. We take the implant. We don't even touch the implant. We just take it straight from the box. We put it into this little funnel. It doesn't work when it's dry like this. And then we squeeze that in. But the main point about all of this, me telling you this, is because if you look at the incision sizes now with silicone implants have become smaller. And that used to be one of the advantages of using a saline implant, is we used to be able to roll up the implant. I can't roll this one, it's a little bit of air in here. But you roll it up into a little, like we used to call it like a little taco, little taquito. We used to put that in through a smaller incision. And then when we were using silicone, we had to use a bigger incision because the silicone implants, remember, they come filled. So we had to kind of squish it down and use our fingers and push. It was a little bit hard on the implant because we're manipulating it. We're touching the implant, which even though we're wearing sterile gloves, we're in the air. There's potential for contamination of the implant. And so now we don't do any of that, and we're not reliant on this to determine the size of our incision. And so we use this, and we can get a smaller incision. So that's kind of cool. And we don't touch it. There's many advantages to using the Keller funnel. But anyway, I'm talking about size, remember. And listen, if this is getting a little bit painful for you, remember this one thing. You'll get this if you stick through it, okay? Hang in there. All right, so let's talk about the size. So here's what I do. I make a little incision. I go in. It doesn't really even matter where we're going to make the pocket, whether it's subglandular, submuscular, subfascial, wherever it is. And what I do is I create the pocket based on the anatomy of that breast. So I have done a lot of pockets over my life. I feel now I have an image in my mind of what I want that pocket to look like. Because I know if I can design that pocket the way I want to, then it'll get the best shape to the breast. So that to me is what is the most important thing, is shape. I focus on the shape, and I don't even worry about the number of the implant. And I know that sounds a little nuts, but the reason I do that is I know if I can get you a good shape, then the rest of it will take care of itself. The size will be fine and the number will work. The shape I'm trying to do is I have to get the proper cleavage. So I have to open up the pocket. Let's say that this is the middle of the patient here. So I have to open up the pocket. You can open up the pocket too far, let me tell you. Fortunately, I've never done that. But you can open up the pocket too much. And I've got a video showing you what happens, a really cool video. And you can open up the pocket too much. So you have to open it up just enough. If you open it up too much, you can connect the two pockets and you get the uniboob, which is symastia, which is a total and utter disaster. It's hard to fix. So you can't open the pocket too much. But if you under dissect, if you don't open the pocket enough, you don't get as good a cleavage as you can. So I don't say this is the implant I have to put in, I'm going to put it in. What I do say is I want to develop that pocket perfectly, so I'm going to get beautiful cleavage. I do the same thing on the outside, the up part, everything. I create the whole pocket. Once I have the pocket created, I know that if I just take the correctly sized implant that perfectly matches the pocket, I'm going to get nice cleavage. I'm going to get fullness up here in the upper pole of the breast, not something that's overly done, just nice. And I'm also going to get some fullness towards the outside of the breast. And I'm going to get, once I get those things, the projection takes care of itself, because there's that volume of the implant will then project the breast. So once I design the pocket, then I use this little handy dandy device. And this is a breast sizer. And I place that in the pocket. And you can see actually that I already do the pocket size to match that sizer. So I've done one or two of these. So here is the sizer, and it goes inside the pocket. and then I just simply inflate it with air. So you can just see it just comes up like this. And I just fill it up until the pocket is completely full. Okay? And so once that implant sizer totally forms the pocket, I can look at the breast. I could say, have I maximized where I want my cleavage to be? Yes, I can. There it is. I don't need to do any more. Has a nice shape in the upper pole? Absolutely. Is it nice on the outside? Is it too flat on the outside? Do I need to open up a little bit more? So this allows me to confirm that I've done a good job creating the pocket. Once I do that, I know the volume of this, and so then I just find what is the implant for that volume. It's this one. I take the implant, I go in through my incision, I use the Keller funnel, place the implant in, it goes in, and you get a beautiful shape. And then I say like, oh, what is the number? Oh, 355 is what gives this patient a beautiful shape to her breast. Now, I always tell patients when they say, well, my friend has 400, she told me to go a little bit bigger, I want 425. Maybe that patient can only have a 280 cc implant. Maybe that patient would be better with a 485 cc implant. So you have no idea what your implant size is based on what your mother, your sister, your aunt, your friend, anyone's implants. Those implants are for their breasts. Every breast has a different shape, has different tissue quality. Some patients' breasts are really stretchy. Some patients are really tight. Some people have more breast tissue. Some people have less breast tissue. So there are so many variables to consider that I said, let's get rid of all those variables. Let me design the pocket. Let me figure out what size it is, and that's the implant that I'm going to use. So that's what I use. So my patients go to the operating room, and they don't know what number I'm going to use. And I always think that this must terrify these poor people. But I explain my philosophy, and I can tell you, since I've done this, since I changed from doing all the measuring and the marking and figuring out exactly down to the last millimeter how big the implant should be, I have very little problems with people not wanting, with people wanting to change implants. So there is some variability to this system, obviously, and I liken it to somebody trying on a shoe. If you're a size 7.5 shoe, then you could probably wear an 8. You can probably wear a 7, depending on the person, the people that make the shoe. But if you're 7.5 shoe, you're not going to be able to wear a 10. If you're 7.5 shoe, you're not going to be able to wear a 4. So there's some limits, but within these limits, there's a little bit of play. So if somebody tells me, I really want to be as full as you can make me, then I will design the pocket, figure out the size, and I'll put something like the next implant up just to get a little bit more fullness for that patient because she wants that. If somebody says, hey, I want to be a little bit on the smaller side, then there's a little bit of play, and I can use a little smaller size. But in general, you have to stay. If your foot's a 7.5, you're in that neighborhood. So you can't come in and say I'd like an 800 cc implant where your breast can only accommodate a 400, for example. And you can, but you'd have to have multiple surgeries and stretch your tissue. And the other thing is really, if you focus on size, then you're missing out on the shape. And what's most important is the quality of the shape. So, at least in my opinion. So that's a little bit about size. Okay, let me take a few questions now, and then what we can do is when we'll come back and we'll talk about, yeah, it's good, it's about halfway, and what we'll do is we'll come back and we'll talk after the questions about all the complications. And I'm also going to talk in a little bit more detail about these Motiva implants because these are newer implant and I've been using these and I love them. And I'm not paid by Motiva, so don't think that. But I love them. They're excellent, and I think they're the best implant on the market now today, in my opinion. And I'm going to go through, after we go through some questions, and I'm going to show you and tell you why I think that. And now that you have some knowledge about where the implants go and different types and whatnot, I think you'll be able to get a better understanding of what the advantages are of using a Motiva implant. But let's take a few questions here. Thank you, sir. And, okay. Good evening. Good evening. Can we get a lift without lift with the fuller one? I don't quite understand that, Motiva. But just in general, to answer that question is, you can get a lift either with an implant or without an implant. And I typically will also use the same implants for a lift that I use for a breast augmentation in terms of the profile, in terms of the style. Usually in a breast lift, I put the implant underneath the muscle. And that's kind of for other technical reasons. I'm using internal bra and things like that, which it's too much to get into now when we're talking about all these different implants. Candy Gutierrez said, I would like to get my BBL on breast. So you can do that. I call that a mini mummy makeover, where you can have a BBL and you can have a breast augmentation. Now, the reason you can do that is because after a BBL, you can lay on your tummy. You have to lay on your tummy. But what patients don't always know is that after a breast augmentation, you can also lay on your tummy. And you just put a pillow above your breast and a pillow below, and that'll help take some pressure off, and then you can lay right on your tummy. So you can get a breast augmentation also with a BBL. So that is not a problem. Oh, but you cannot get a breast or a BBL with a breast reduction or breast lift with an implant, because I don't want you laying on your tummy if you've had a breast lift, because it will put pressure on the nipple and the areola, and we've changed the blood supply when we do a breast lift. So I'll do a breast BBL with a breast augmentation, but I won't do a BBL with a breast reduction, breast lift, or breast lift with an implant. Okay, yes, 312s asked me a question. Can you compare the cohesivity with Motiva Round versus Mentor Boost? Which one will give you more upper pull? Okay, that's a great question. Let's talk about that. Diana, thank you. It's very nice of you to say that. Okay, so what's the question? So let's talk about that. I said I was going to talk about the Motiva implants, and this is a good question to do that. I'm just going to launch into that right now. So here's there's so many things to know, but here's what you need to know. So with the Motiva implants, okay, this is a new implant on the market. It's been out for over 10 years and used in Europe and over 85 countries, and I think there's been 4 million augmentations, or they've been used in 4 million different surgeries. So it's got a tremendously good safety profile. This is also a 6th generation implant, and that is the newest generation implant, and this is the only 6th generation implant on the market in the United States. So how does that compare to a Mentor? I don't think I have their Boost here. I do have one of their implants. So let's just talk about a few different things, and why is this a 6th generation? Why is it good? And why do I like it, and why am I using it? Well, so first of all, you talked about the cohesivity of the implant, meaning how sticky is the gel. Well, the traditional 5th generation implants, they're also called gummy bears, and the 6th generation are called gummy bear. So what does that really mean? Well, what we're talking about is the silicone inside, how that silicone is bonded together. And I don't pretend to know how it's bonded together. All I do know is that you can have implants that have different bonding styles based on the implant manufacturer. And these are the most cohesive ones. So they stick together the most. If you were to cut this implant in half, I do have an implant. I could see if I can just open that up. Where's that one here that I use? Okay, this is the other implant. Remember, I took this is the implant where I took that little chip out of there the other day, and so you can see that you'd think, oh, if this implant is open, this isn't implant open, it would pour all over the place, but it's not. This is a very cohesive, and this is the most cohesive implant. And having this implant, that's why they call them gummy bears, because if you cut this in half, it really looks more like a gummy bear. It's kind of like a solid, and yet it feels and looks like a liquid. But that's why if you open these up, they don't just pour everywhere. This just is I'm not going to touch it because it's quite sticky. But it's like a very cohesive solid feel to, or cohesiveness to it. So these are more cohesive. These have a totally different shell. So if you go back and you look at, remember I told you that this implant here was an anatomical implant and it was textured so that it'll stick and it won't turn. But there's actually another reason for the texturing as well. And texturing caused a lower rate of capsular contracture. But then we found out, texturing is bad because it's causing that breast implant associated lymphoma. So we said, okay, texturing is not good. But texturing was decreasing the rate of capsular contracture. So this is kind of like a perfect balance with the new implant because it has a tiny, tiny thin layer of texturing. They call it actually silk, a soft silk. Tiny bit to decrease your rate of capsular contracture, but not the big, harsh, rough texturing of implants in the past that were causing problems with breast cancer. So this is sort of like the best of both worlds. Decrease the rate of capsular contracture to less than 1%. And we're going to talk about that in a moment when we go through the complications. So this texturing and the combination with the texturing and the cohesiveness of the implant have decreased those complications. There's also less rippling with this implant, and there's also less rupture. It has a less than 1% rupture rate. And when I don't know the exact rupture rate because there's a lot of different studies with the implants, but in general, the implants that we used to use in the past, they were all about a 10%, 11%, 13% at 10-year rupture rate. And this one has a 1% rupture rate. So the other thing about this in terms of the fullness, you're asking about the cohesiveness and the fullness. So they have two different styles of this implant. They have a fuller, more cohesive one that gives you this more round, more upper pole fullness, or they have their softer implant, which that's the same one. Let me feel. Yeah, this one here. So they have a softer one, which let me just grab. Here it is. You can tell right away when you feel it. So they have a softer one, which doesn't have as much upper pole fullness. It gives you a little bit more natural look. Still going to be a very pretty breast, but it's a little bit more natural compared to the one that is round on the Motiva. So two different Motiva implants. One is a little bit softer. It's called ergonomics, and one is gives you a little bit more upper fullness. That's the round, the regular. So those give you more fullness, more oomph in the upper pole than the other implants will give you. All right, let me go through a few other questions here.
Go all the way to the bottom.
Go all the way to the bottom.
More questions came in.
Okay, you're welcome for that. That's awesome. Okay, I don't want to live. Okay, let's see. All right, Alicia's calling me Dr. Miami. That is not me, but what are my thoughts on saline implants? So that's what I was talking about at the beginning of the live, and that is I prefer silicone implants much, much more than I do a saline implant. I think silicone implant is a much better option. Where's the question here? If a lift is recommended, is it a must? The answer is yes. I don't want to lift, but a full high profile. Okay, that is a misconception that you can have a full high profile implant and that will take the place of a lift. But that is not true at all. And if you have a droopy breast, let's see if I can draw that here. If you have a droopy breast, okay, let's say here's a breast without droop, and then can you see that?
Yeah.
Do I need it bigger?
No, just move the iPad out of the way.
The iPad out of the way.
Yeah, move it up.
Okay. All right. So here's a breast without droop, and then here's a breast with more droop. So what you have to realize is that the implant, when we put the implant in, the implant goes here. There's a correct location for the implant. So if the implant is here and your breast, it's not going to lift your breast. Your breast is not going to magically just come up because you put an implant in. It doesn't work like that. Your breast stays in the same location. So if you put an implant there and then you didn't do a lift, your breast is still here, that will not look good. That'll just be an implant where it should be, and then your breast falling off of it. That's a waterfall deformity. That's not anything that we want at all. So if you need a lift, you need a lift. Doesn't matter the profile, saline, silicone, smooth, textured, high profile, low profile, makes no difference. If you need a lift, you have to have a lift. And you cannot just work your way out of a lift with an implant. That is a very dangerous game. I've heard it played many times. I played the game myself. I can remember very clearly starting off and doing early on in my career and having a friend of mine and reviewing a photo with him and saying, hey, do you think I need to do a lift here or I can just do an augmentation? And he's like, just put a bigger implant in and you can auger out of that. And that's kind of the phraseology. And it doesn't work. If you need a lift, you have to have a lift. Otherwise, you're just not going to get a good result. Okay, let me take a few more questions. We'll have time for questions again later. So if you do have a question, you can type it in and I'll answer that later on. Can I get an implant before a tummy tuck? Yeah, there's no bearing whether you have a tummy tuck before or after or anything like that. And let's see. How long would you have to stay in Miami after breast lift with an implant? With somebody says, is it true the BBL smell like rotten flesh? No, that's not true. That I don't know why. That was like clickbait. People posted that so they could get more views, but it's not true at all. I mean, I probably wouldn't be doing BBLs anymore if every single patient came back with a terrible odor. I would probably retire. How long would I need to stay in Miami after breast lift with an implant? I would have to fly in. So with a tummy tuck or BBL, I tell patients you should stay here at least a week. But with breast, it's much shorter. It's really 48, 72 hours. We really just want to make sure, and I'll talk about this complication in a minute, that we just want to make sure you don't have any immediate problems. And once we get you out of that first 48 hours, it's unlikely to have problems afterwards. Okay, Mabel is asking me, how do you determine what is good when one breast is bigger than the other and one is up and the other is down and all that? So that's asymmetry. And there's a lot of different things we do with asymmetry, and it's way too complicated to get into here. But suffice it to say that we can give you symmetrical breasts. Now, when I say symmetrical, I mean normal symmetry. So everyone has small variations between the sides of their bodies. That's normal. 100% of patients have that. So, but if you really have something that's unusual looking, there's a lot of asymmetry, then yeah, sometimes I have to reduce one size, do a lift. There's so many different combinations, but we can do all of that. And asymmetry is a reason to use implants sometimes as well. Deanna asks, hello, Dr. William, would it be possible to combine fat grafting with implants in a single procedure? Yes, that is possible. I do that quite often. Different situations, again, fat grafting. I'm going to be doing a live on fat grafting to the breast because it's a big topic in and of itself. But yes, you can combine implants with fat grafting. Most patients don't need it, but some patients will benefit from it. So it's a case-by-case basis. These implants are just really beautiful. They do a good job. I find I don't need as much fat, really. But some patients still, yes, there's areas that we can apply fat and can help. Okay, let us move on. I'm gonna put the questions on hold. We'll come back. We'll do some more questions here. And let's talk about the complications of breast implants. So, you've heard me mention capsular contracture. You're probably wondering at this point, well, what is it? And we're going to talk about everything. But let's specifically talk about capsular contracture. So this is an example of capsular contracture where a patient will have, if you look between her breasts, you see where my mouse is moving here on this breast? Do you see how that breast is rounder and kind of balled up looking compared to the other breast? She's obviously had these implants for a very long time, and that is what's called capsular contracture. So capsular contracture is when you have an implant, any implant, it doesn't matter, smooth, round, anything, implant that goes in your body will not reject it. There's a common misbelief that your body will reject an implant. It's impossible. Your body doesn't reject it. If I gave you my kidney, your body could reject my kidney because my kidney have my receptors that say, hey, this is William's kidney. Your body would say, hey, that's not my kidney, and it would kill it. These implants, they don't have any antigens on them. So your body can't kill it, reject it. So what does your body do with it? Your body says, I don't know what this is, but it looks like she's keeping them, so I better do something with them. So what your body does is it forms a capsule around the implant. 100% of patients will get a capsule around their implants. Not 100% of patients get a capsular contracture. So, God, I sounded like a male Karen there for a moment. Okay, so the capsule is just a very light tissue. Just imagine almost like a piece of Kleenex that goes around here. And in most patients, the capsule will remain soft. But in some patients, and it depends on where the implant was placed, what type of implant is, can develop a capsular contracture. So when I first started practice, I would tell patients, you have a 10% chance of developing a capsular contracture in your lifetime, meaning the implant goes in, you develop a capsule around it, everyone has that, but about 1 in 10 patients would go on to develop a capsular contracture where they would look like this patient, where they would have a firm, hard breast, and that breast, the capsule can contract around, distort it, and move it. So that was 10%. And as time has gone on now, there's certain things that we do. I'm going to talk about what we do to try to decrease the chance of developing capsular contracture. There's a bunch of things that we do as surgeons to prevent that. But now we have, for the first time, a very, very low capsular contracture rate. Their data is relatively short in terms of the length of time. I imagine, this is just my speculation, that we might see these have a little bit higher than what our data tells us now, but still incredibly low. Right now, we're looking at about 0.5% of patients developing a capsular contracture from this Motiva implant because of the surface and because of the 6th generation gel that's in here. It's just a better technology. There's other things related to their shell as well. They use this very interesting kind of one-step manufacturing of the shell, which is really pretty cool. So with that now, our capsular contracture rate is going very low. So it's phenomenal. This is really one of the more exciting things that I've seen in plastic surgery in a while. So anyway, if you develop the capsular contracture, it's not harmful to you. You could have this capsule forever, but most people want to have something done with it because it can bother people. It can become painful. Not everyone's capsular contracture is painful, but it can. And it can distort the breast, and patients don't like it, or they don't like the way it looks. Sometimes they don't like the way it feels, or sometimes it bothers them when they're sleeping on their side, or all of the reasons. And they say, hey, I want to get the capsule removed. So what we'll do is we'll go in, we'll remove the capsule, remove the implant, we'll put a new implant in. And there's a little algorithm here I just want to share with you. I don't want to go too detailed, although I am, what? I'm an over-explainer? You don't say. So yes, I know I over-explain things, but I just want you to understand so badly that I just want to keep explaining until I feel that you really got it. So here's just a general overview, okay? If you have a capsular contracture and you just have it on one side, then what we typically do is we'll go in and do what I just said. Remove the implant, remove the capsule, put a new implant in, and we'll start again. If that fails, so if we follow along our little algorithm here, so let me just explain things. So you see that first gray box, laterality of the capsular contracture. That just means, excuse me, is it on one side or is it on both sides? If it's on one side, then we'll go in, we'll remove the implant, remove the capsule. If that capsule comes back, because you do have about a 30% chance of that capsule coming back. If that capsule comes back, then what we do is we will wrap the implant in a pigskin. And yes, pigskin, but there's no cells in there. And so we wrap it there, and that will almost bring your capsular contracture recurrence rate to 0. This is data done 5 years ago by Dr. Hidalgo. Now, if it turns out you have capsular contracture in both breasts at the same time, then we don't do the traditional treatment of just removing the implant, removing the capsule, putting a new implant in. Then we go straight to using the pigskin because you're way more likely to have a capsular contracture recur if you've had it in both breasts. So that's an important thing to understand. I always tell patients when they have a consultation with me, I usually will ask them, do you know about capsular contracture? And usually patients will say no, which I think is really a shame because a capsular contracture, in my opinion, is the most important thing to understand. We're going to talk about a bunch of complications. This is the most important one to understand because it's the most common reason for reoperation after having a breast implant. And so it's important to understand capsular contracture. I tell patients there's one thing that you've learned from this consultation, and that is what a capsular contracture is, how we can treat it, and the different options. Here's just an example of this is an old one because I'm using an anatomical implant, but that's an old photo of where that implant gets wrapped into they would call it ADM, acellular dermal matrix, or the pigskin, and that reduces the chance of you developing a capsular contracture. Okay, let's go through a few of these complications. So reoperation, so that is a complication. You can reoperate for a lot of reasons, and we're going to talk about those, but one of them is asymmetry. So perhaps your did not achieve symmetry the way we thought you would. That could be a reason for reoperation. You might be unhappy with the implant size. You want to make bigger, it's smaller. Perhaps if you had your implants for 10 years and you've decided, or you lost a lot of weight, or you've had a change in your lifestyle, maybe implants aren't right for you anymore. So there's other reasons for reoperation. Capsular contracture is the most common. Now, you can have implant rupture. So this is an interesting topic. If you have implant rupture of a saline implant, remember, this is a saline implant. Right now it's just filled with air just to show you. But we fill it with saline. And with the saline, if this ruptures, if it breaks, then we don't really call it a rupture, we call it a deflation, because the water will just come out, it'll leak out, and your body absorbs it, and then you'll wake up with one boob and no boob. So that just becomes flat. It's not an emergency. If that's happened to you, you do not need to call your plastic surgeon the next day or 2 in the morning to report an emergency, although that happens because it can make you freak out a little bit. But it's really not an emergency. The water has just come out and your body absorbed it, and there's no rush. You don't even need to ever have surgery if you didn't want to. You could keep that ruptured implant inside of you forever. It's not doing any harm. Most people don't want to do that because they don't want to live with one breast deflated. So if an implant ruptures, or in this case saline, it will deflate. If a silicone gel, implant, and remember these Motiva implants have a lower rate of rupture. It's incredible, 1%. But anyway, if whatever implant you have, if it's a silicone implant and it ruptures, you most likely will not know it's ruptured. And that may come as a surprise to you, but I'm going to show you on this little one where I used a little chip, okay? So let's just say you have a break here. Let me just back up. I think patients always think that they're going to have an implant rupture if they're in a car accident or they're in some altercation or they have a fall or something. They sustain some trauma to their chest, so they get some impact. Well, these implants are phenomenally strong. These implants, you'd be hard pressed to break these implants. These are incredibly durable implants. We always have these laying around in the office, and twice in my career have the implants broken when patients have been in there and like, oh, and you know, I feel embarrassed because like, oh, I'm like, these implants don't rupture, and then you know the little kids holding the implant, next thing you know, it's like broken. It's their nails. So I've had a couple little, ironically, it's been two little boys. Surprise, surprise. Little boys liking boobies. And they're kind of playing with it, and they nick it, and then it can break. But they don't break really from the impact. They break from wear and tear. So I usually imagine, you know, you ever driven down in the country and you see like a barn that's just about ready to fall over? Well, that didn't happen just in the last week. That has been happening for the last 20, 30, 40 years. Day by day, the nails get a little looser, the wood gets a little softer, a little more rotten, and eventually the barn kind of falls down. That's really the way I imagine breast implants failing or rupturing. It's not a sudden boom, but it's just daily wear. And sometimes they will describe, and I think that's why I'm not an expert in implant technology, but I think that's why this one has a lower rupture rate, because these are 100% filled. Not every manufacturer fills their implant to 100%. These are 100% filled. This is a different material made in a different way, and I think it's stronger, and it doesn't have as much opportunity to create these little wear spots. But what I've seen and what I've read and what's been reported is implants tend to rupture because when the surgeon was closing, he or she nicked the implant with a needle. That can happen because the implants get sent back to manufacturer. Manufacturer's like, hey, why did this implant break? And they're looking around like, little needle mark there. So that can happen. Or they can just kind of wear and tear over years of little friction, a little fold, a little crease that wears and then it breaks. But the reason why that if you have a saline implant, you're going to know it's broken because one of them is going to be flat. But with a silicone implant, you see this. I'm just going to remove this little chip here just to get that out of the way. So we'll put that there. So that little chip, okay, I made an incision in there to remove that chip. So now you can see if you have that inside of you, the implant looks the same. Your breast looks the same. You have no idea. There is a tear in that implant. You wouldn't know because of the highly cohesive nature of the 6th generation gel. You don't know it's broken. Even if some of it starts to come out and you move, you put some pressure, it's going to go back in when that pressure is relieved. And your body has a capsule around this already. So even if, say, some were start to come out, it's not going anywhere because it's covered by that capsule. So you usually only find out that an implant is ruptured when you have an MRI or CT for some other reason. You might be in you might have pneumonia and you develop or you need a CT scan to be assessed, and then they say, hey, you have a left lobe pneumonia, and by the way, your right implant is ruptured. So if that's the case, but it's an internal, the capsule is intact and everything doesn't really look bad, you don't have silicone leaking out everywhere, it's what everyone thinks, but you just have this little rupture and you don't even know, it's just sitting there contained by that capsule, you wouldn't even know. And even if you come to see us, we typically don't do anything. Now, some patients say, well, I've got an implant that's broken, I want it to change, we'll change it. But unless the silicone has gone beyond where the natural capsule of your body has formed around the implant, we don't even suggest replacing the implant. So, okay, rupture. Asymmetry. Asymmetry can be a complication, but everyone has some degree of asymmetry, but we're talking here noticeable. Not really that common. You can have changes in nipple sensation from the implants. That's possible. Again, fairly low percentage for patients to have that, but it is possible. It's why I recommend all patients actually perform touch of their breast immediately after surgery and for the first couple of months, so that will help with the sensation and help with the nerve regeneration, and help prevent the nipples from getting too sensitive. But it is possible to have loss of sensation having breast implants, although it's not particularly common. Rippling is what I was mentioning before, where you have that kind of scallop look on an implant, more common with silicone, much less with these nice Generation 6 Motivas. Anytime we're operating, you can always have a hematoma or a seroma. Hematoma is just blood, so it's not very common either when we're operating. We're dissecting, we're cutting vessels, we're coagulating them, we're stopping the bleeding as we're moving along. But it's possible to have a hematoma after surgery, in which case one of your breasts would be noticeably different than the other. And the skin gets shiny and you can see some bruising. If that's the case, what we do is we take you to the operating room again. We open the incision, we remove the implant, we wash it. I have an acid that I use by Dr. Fisher. I wash out the pocket. We look for any bleeding. If there is something bleeding, we stop it. We wash everything out, wash the implant out, and we put the implant back in. Seromas are fairly uncommon, and particularly with the Generation 6 Motiva implants, there's a lower rate of seromas as well. Infection. Infection is a dreaded complication. Nobody wants to have an infected implant, because if you have an infected implant, the implant has to come out. And that obviously is not an optimal situation where you had 2 implants placed and now one of them is infected and it has to come out. It's got to stay out for a few months until your body has cleansed the infection and we go back in. I'm going to be talking, as you know, I love to talk about recovery. So I'm going to be talking a little bit about recovery. And when we're talking about recovery, I'm going to talk about infection and the things that you can do to prevent it, to prevent the infection. That's coming up shortly. You can have implant malposition. So the implant can go into a place where you don't want it to go. There's a variety of reasons for that. Sometimes the implant is too large for the patient, and so the implant will always win. So if you're trying, and I see this unfortunately in Miami not uncommonly, patients will come to see me and they're not happy with the shape of their implant. Well, why aren't they happy? Well, their implant, instead of looking like this, roundness, their implant will take on a more oval shape. And it will look like a more oval shaped implant. And why does that happen? Well, that happens because they didn't pay attention to the actual dimensions of the pocket and they wanted to put a big implant in. So they put the implant in. Well, the implant will go where it needs to go. It'll create its own space. So it'll steal tissue from everywhere. It'll steal tissue from the abdomen. It'll take abdominal tissue up. It'll take tissue on the side. You'll get sort of a distorted breast. Or the easiest place for the implant to go, because the path of least resistance is straight up. Because the implant, if you force it in, it can open up that area that you haven't opened. But in order for it to fit, it's got to open that tissue itself. It's kind of like your implant is deciding how your breast augmentation is going to look. That's why I don't go by the number as the determining reason how to do it. If someone comes in and says, I want this implant, well, it may not fit. If I could put it in, then it's going to look weird because it has to steal space. So that's an implant malposition from either an implant that's too large, the pocket wasn't dissected correctly, or it was over dissected, and you can have the pocket can go way to the outside, or the implant can bottom out. Tissue can be very poor quality. An internal bra is not used, mesh is not used. A lot of different things where you can get implant malposition. That's why it's important to have an appropriately sized implant for your body put into a nice hand and glove pocket. So, scarring issues, you can have kind of 3 different results of scarring. You can have some healing problems, which are minor, a little separation of the wound. We really don't see that very often at all because we're usually dealing with young, healthy patients, and we're non-smokers, and it's a very short operation, and we're not removing any tissue. We're just opening and closing. So we typically don't have any problems with the way our incision heals. You can develop a hypertrophic scar, meaning a scar that's kind of thick, or you can develop a keloid scar where that's very thick. Now, it's not really that common to develop a keloid on the breast. It's more common to develop keloids in areas of high skin tension, the back of the head, the neck, the shoulders, the upper chest. Those are all more likely to develop keloids. The breast typically heals without keloid, but it's possible, but it's pretty rare. You can have BIA ALCL. What does that stand for? That's breast implant associated anaplastic large cell lymphoma. That's why we call it ALCL. That is associated with those textured implants that are no longer on the market. So the risk of that should be, the incidence of that and the risk should be going down with time. Basically, the story, and listen, I would not say I'm the world's expert on ALCL, but I've done obviously a lot of reading about it, and the current reading, the literature, and essentially that is a lymphoma that starts in the lymph nodes because there were textured implants, and not this particular implant, but this style with the texturing. Some of that texturing kind of came off, and it would go to lymph nodes and create an inflammatory reaction which caused this lymphoma. So the treatment is pretty straightforward. You actually just remove all the capsule of the implant, and that's your treatment. But let me just talk for one moment about that in relates to texturing, okay? And that this is where you're really going to need the reminder of this, because I'm going to go into the woods a little bit here, okay? Hang on, follow me through the woods. When we get out of the woods, this will be on the other side with a nice glass of Chardonnay or whatever your drink of preference is. Okay, let's just talk about texturing for a few minutes. There's different types of texturing. And the interesting thing is that different companies came up with a different way of texturing. Remember, they came up with texturing to decrease your risk of developing capsular contracture. But that texturing caused problems. But not all texture caused problems. So what was it that caused the problems? Well, different companies had different ways of coating their implant. So in very rudimentary ways, some took a implant and kind of almost in a way, you imagine, sort of rolled it to get kind of a rough stippled pattern. Other manufacturers had the implant and then they sprayed it on with the texturing onto the implant. Well, it was that one. It's a salt loss, but anyway, that kind of technique made that stuff easier to come off, and it was those little things that created the problem. So it's really that has been the most patients with ALCL have been related to having that type of implant or an expander for breast reconstruction, stuff like that. And that was the reason for it. So now that we're not using those textured implants, I would expect over time we're going to see fewer and fewer and fewer of those cases. And we didn't really know that that entity existed. And we start to recognize it and see it, and we're like, there is a problem. And then those implants were identified, taken off the market, and so it's not really a problem. The final complication is breast implant illness. This is an entire discussion in and of itself. We don't have good scientific data to suggest that implants make patients sick. That's what our literature says, studying tens of thousands of patients. We can't confirm any type of link. That is not to say that there are not patients out there that have had implants, got sick, and had their implants removed, and they felt better. That's also true. It's just that we don't really understand what's going on. And most of the information that is out there, in my opinion, that is explaining the reason for this have been disproved. So we're in this kind of weird situation where you're like, well, we don't have the data to say, yes, this is an entity. You need to have data and symptoms and signs and things that you can study and prove to be able to prove an effect. You can have an implant and not feel well 3 years later. It doesn't necessarily mean it was your implant. It could be a variety of reasons. So there's something that's called true, unrelated. Meaning, I had an implant and I got sick. But both of those things are true. It doesn't necessarily prove causality, meaning this caused that. They can both be true and not be connected. That's kind of where we are in our literature. The difficulty is that we all, as surgeons, meet patients and they explain things to us. Well, there's got to be something there. It's sort of like if there's smoke, there's fire. I think it is a relatively small subset of patients that have issues, but I do think there is some validity there. I would not discredit those patients, but it's not as if 100% of patients get better. So there's a lot of gray area, and I think just as it's taken us a long time to work out implant technology and everything else, we're going to be looking at this problem for a long time. But from what I've seen in my patients, most patients don't go on to develop it. So I do think there's something there. I don't think it's particularly common, but it's something to at least understand. Okay, I'm going to talk here for about 10 minutes on the recovery protocol and some things to recover with breast implants. Before I do that, I'd like to take a few more questions. And should we take some questions now, or you want me to continue on?
Let's take some questions.
Take some questions? Okay. So we'll take your questions. If they could be related to breast implants, that would be best. But I'll go through and try to answer them here. Okay. Can you get an augmentation? This is Miss Allen. Can you get an augmentation with a wide breast, and what's considered a wide breast? Super good question. I don't have my slides up that I could really quickly show you that. No, I can't. Because I don't think the nipples are covered up in them. But anyway, here's the deal. If you have a wide breast, don't get a breast implant. You're going to be disappointed. You're going to have multiple surgeries to try to correct it until you come across somebody who is brutally honest, such as this guy. And I mean, when people tell me on YouTube, they're like, hey, you're fat. You need to have lipo. I'm like, yeah, I know I am. I have a mirror. I look in the mirror. I can see that. But I'm not a candidate for lipo because my fat is internal. Although I have lost quite a bit of weight, I got a lot of more to go. Take a Manjaro. That's a topic for a different day. So anyway, but I'm honest. I'm honest with myself. I'm honest with patients. I don't want to lead patients down a garden path, tell them a story that's not going to work out. So in my opinion, if you have a wide breast, you're not a good candidate for an implant. I've seen it so many times. I've had many patients come to see me with wide breasts who have implants done by other surgeons, and they say, my last surgeon was terrible. I need you to fix this. And I say, your last surgeon was not terrible. It's not a problem with the surgery that you had. It's a problem with your breast. I personally don't think it's a good judgment to put an implant in a patient with a wide breast, but technically nothing wrong was done. And the reason is very simple. This is the size of a breast implant, okay? There is a certain dimensions to it. Yes, we can have a bigger implant. We can have a bigger implant with a wider base to it. And the larger volumes go up, the wider the base unit. So if you have a wide breast, we need to use a bigger implant because that fits your breast. We're always trying to design the pocket and the implant to fit perfectly. Hand in glove. Manos o guantes. So what we can't do is if you have a very wide breast, we can't find an implant that's going to fit. And so if your breast is this wide and the implant is this wide, or the implant is this wide, breast is this wide, the implant's just going to drop. And your breast can't hold the implant. So you end up with a wide, heavy, droopy breast that does not look better. So I don't have any dimensions to share with you in terms of size. I had a patient come in the other day and she had seen another surgeon talking about a lot of breast dimensions. I didn't really need any dimensions to know, just to look. The patient's breast is very wide. Their breast is not on their chest. Their breast actually continues over. And if you find the side of the breast, it's actually off the chest towards the armpit. So for those patients, those are wide breasts, and implants are not a good idea. They do not look good. And if you don't believe me, come in and see me because I can show you a bunch of pictures. And I'm ruthless when I show the pictures. Because patients who have wide breasts and they're really, really stuck on getting an implant, I have to say, do you like this one? And they say, no. And I'm like, do you like this one? They say, no. Say, do you like this one? They say, no. And I know they're thinking, like, how many more is he going to show me of this? Well, I'm going to show a lot. I go, dong, 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 because I want you to understand. And it's not just one person has a wide breast and that implant, but everyone with wide breasts, none of them look good with implants. Okay. Over-explainer much? Hello, yes I am. What is the price, Giovanna Cavazos? I don't do any of the pricing, so honestly, I don't know. I mean, I have a ballpark idea, but I don't go into that pricing. So if you wanted pricing, you could contact us, and someone will give you pricing. What technique would you use for tuberous breast? Woo! I love tuberous breasts. Okay, tuberous breasts. I think I have some photos here. Do I have photos? Let's see. I can't remember. Let's take a look here. I have some before and afters. Everyone loves before and afters, so I have before and afters to show you. Just wanted to see if I had a tuberous breast. I thought I put a tuberous breast in. To be honest with you, I can't remember. Shoot. I don't. Oh, yes, I do. Okay, here we are. Okay. Here's a tuberous breast. Again, this could be a whole conversation. It's fascinating to me. It's really tough, and it's very difficult to show doing a live like this because we have to cover the nipple, and that's really where all the action is the tuberous. So, yes, I do tuberous breasts. I love to do them. They're complicated surgeries. I use Dr. Hammond's approach. He taught. I went to see him operate. And I follow that. And ever since I've been doing that for probably about 8 or 9 years, I really like my results of tuberous breasts. And what we're doing is the bottom line is with the tuberous breast, you can see this. Let me see if I have. Yeah, so you can see it's a breast that doesn't develop along normal developmental lines. And so you kind of get this very wide areola as this breast is trying to develop through this little sort of ring that's kind of constricting it. We have to go in and kind of cut that ring open, and then we use the implants to be able to give a rounder shape. Here's a picture of somebody with tuberous breast. You can see that her left breast here, where I have my mouse, was very underdeveloped. The fold to the nipple was only this big, so you have to recreate. You're basically recreating a new breast for the patient, and then you're using the implant to maintain the new breast that you've created. So implants are wonderful for tuberous breasts, and some of the most happy patients are those with tuberous breasts. I actually have quite a few photos of them, but they're not organized into a talk like this. So, okay, let me go back. Where are we going? Where was I here? I was right here. Okay, let me take a few more questions. Can I explain a double bubble? Oh my God, Dia, you like our breast expert. I briefly explained a double bubble, but your questions are require lengthy answers, and I'm already starting off lengthy. Let me explain a little bit what a double bubble is. We'll see if I can do that here. So a double bubble is where you have your breast, and you can have an implant. Let me put the implant in a different color. You can have your implant in here, and everything is hunky-dory, everything's great, okay? Problem with the double bubble is when you have your breast, and then you get this. And so your implant actually comes down below. And so you get this double bubble. And it is, I love to fix them actually. They're kind of fun to fix. I mean, when you're a surgeon, like operating is fun, and the harder the problem, the more fun it is. I mean, unless you're starting out day one in practice, and then you have a hard problem, and you just want to just about shit your pants. You're like, you're so nervous, like, oh my God, and you stay up all night reading and studying and talking to friends and talking to old professors and going through this. Well, once you get more mature in your practice, then you're like, I love problems. Give me problems. So a double bubble is a great problem to fix. And it's a little tricky, but what you have to do is you're trying to reestablish this normal anatomy here, where this comes in and you have a nice crisp fold, whereas the implant has come down below where the fold is, and it's created that bubble. So you have to reestablish where this fold is and get the implant into the correct position. So quite often I'll use a mesh in this way, or people call it an internal bra. I mean, we've been using internal bras for years, but now everyone's calling everything internal bra. But anyway, I use a piece of mesh in there to kind of get the implant where it should be, and then we have to focus on reestablishing with sutures where that fold is. But if you can fix a double bubble, you're doing good, and it's really nice. Patients really like it. It's very gratifying because it really looks terrible. And you want to know the reason why you can get a double bubble? Oh God, why maybe I've been asked why did I even ask that question? Okay, here we are. There's a breast. Can you see that? Yeah. Okay, so here's a breast. Well, there's a certain distance between these two, between your nipple. So if we're looking at it from the side, between your nipple and between where your fold is, there's a certain distance. Okay, and most people have the standard distance 5-6 centimeters, something along those lines. Tuberous breast, those patients are very, very risky for developing the double bubble, and you have to recognize who is at risk for developing double bubble. And the patients at risk for developing the double bubble are those who have very short limbs here between their nipple and their fold. It's very short. And so if you don't address that at the beginning, or if you try to use an implant that's really big and you're going to exceed this distance here, you're going to have an implant that's going to be just too big. You're going to create a double bubble. So you have to, it takes some experience to see patients and be like, oop, that one's a risk for a double bubble. Fine. Oop, she's a risk. You have to identify them, and you have to go in when you're doing your breast augmentation and realize, and you also have to coach and tell the patient beforehand. So a few different things. So anyway, so double bubbles, tricky problem, but it's correctable. Let's see. Can you inform implants about bottoming out? Bottoming out is really just a weakness of the tissue, or an over dissection of the pocket, or an implant that's too big, or all of the three that can create that bottoming out where the implant just falls. We need to reestablish the pocket, close the pocket down, use an internal bra to correct that. Okay, one more question. Miss Miko Sky, says, what's the benefit of wearing a breast band? I'm going to have a breast augmentation next week and considering buying one, even though my doctor didn't mention about it. Okay, I don't use them. What you're talking about is a bandeau. When I first started practicing, I used to use them. It's a band that it's like a I don't know, headband almost. Just a band that goes around. Usually has a little Velcro, and patients will put it around, and it's supposed to keep pressure pushing down on the implants. Well, that's really old technique, in my opinion, because if you go back in time to when implants were first done, remember I said they're underneath the... No, you don't remember because you weren't here, because you were like, oh my God, this guy's droning on forever. But remember I said, hang on, I lost my train of thought. We're talking about... breast band, thank you. So the breast band. So if you go back in time, implants were placed under the gland. In the 1960s, 70s, there was a problem. They started to go under the muscle. And once they went under the muscle, they found, oops, all the implants are really high about people's chin. So then they said, all right, we have to start to cut the muscle to allow the implant to come down. So in the older times, it was really common for implants to be very high because they were under the muscle, but the muscle wasn't cut, so it didn't allow the implant to come down, so the implant stayed high. So we had patients wear this band to try to force the implants down to stretch out that tissue. We don't do that anymore. We are much better at creating the correct pocket to begin with, so the implant is already in the right spot. So you don't really need pressure. It's probably why your surgeon didn't mention it to you, because he or she doesn't use it because it's not necessary. And I anyway, don't want pressure putting the implants down. I want my implants to be up. People want implants to be up. So I don't think it makes any sense to put it down. And I don't think you need to, because of the way we create the pocket nowadays. The implant, when I leave the operating room, the implant is in the correct position where I want it. It's in exactly the correct position where I want it. So all I want to do is I use a Easy Bra for the first 5 days, and that'll keep everything just where they are. I like to have mine almost like the carrying a football sort of thing, where you're running and everything just stays in place. I don't want pressure pushing them down, so I don't recommend a bandeau. All right, I said one more question. That was one more question. And let me ask one more, because I'm reading here. Cassandra Rodriguez said, do implants with lift affect inverted nipples? And the answer to that is most of the time no. An inverted nipple will stay inverted whether you have an implant or not. Occasionally, I have seen patients with very mild inversion of their nipples. And they will have a breast augmentation, and they'll get their nipples will kind of pop out a little bit. So I have seen that, but those are in mild cases of nipple inversion. In true cases of an inverted nipple, the nipple itself, this is the nipple, we kind of draw that on the breast like that. But in an inverted nipple, it's actually tethered to the tissue underneath. So when you go to correct an inverted nipple, it's kind of fun. You actually release these bands here. You take a knife and you just cut them, and you can feel them pop, and then that nipple will come out. But if you have just a mild inversion, some patients will have a mild inversion, and then when their muscle contracts or their nipple gets stimulated, the nipple will come out. Those patients usually will pop out with an implant. But most people don't have that type of inverted nipple. Most patients have one that's truly tethered, and it won't pop out from an implant because that tissue, those little bands, need to be cut there. Okay. Now, we will take some questions. Again, I see there's more questions. Let me go through a little bit more of this, and then we'll wrap up with some questions, and then I'm going to give you the link to get the guide. Okay, so just 10 minutes briefly on recovery. What have I done with this pen? We're going to take just a brief tour through this recovery protocol. I have recovery protocols for every procedure that I do. And I've kind of worked these out over the years, and then now I've just kind of put them in one spot. So before surgery, I have everybody use Bactroban up their nose. And that will kill MRSA, the methicillin-resistant Staph aureus, and that will decrease your chance of getting an infection. I also use another antibiotic, antiseptic in the pre-op room where that goes up the nose as well. Because why are we putting goop in our nose to kill bacteria? Because that's where the bacteria live. And that's where bacteria that can infect your breast implants actually come from. And I think most people think they come from the surgeon, but it's not true. They actually come from the patient. It's a great study done in Washington, University of Washington, showing that. Anyway, so I clean that. So patients will take Bactroban for 5 days before surgery. Then we do some swab as well in the pre-op area. Then we also will have the patients wash with Hibiclens the night before and the morning of to wash their chest, paying particular attention to the nipple and the areola. And then after surgery, you'll wake up in an OG Easy Bra, which is really not just a bra, but it's a dressing and a bra. It's fantastic, super adjustable, very, very comfortable. In fact, I had a patient on Monday tell me, because she was, I have patients wear the Easy Bra for 5 days after surgery, and she was coming near that, and she's like, can I get more of these? Because they're really comfortable, and they're very, very soft, and they are supportive. So that's really great. I start all my patients in that for 5 days. After that, I transition to them to the OG Bra. This is a prototype. This has not been released yet. There are a few little adjustments that we need to make. Don't tell anyone, but I'm using AI to do that. So what we're going to be having is this will be your post-operative bra after the Easy Bra. Can you see me back here? Does anyone see me? So, but this is really supportive, and the beautiful thing about this, and this is a prototype, it's coming soon, is that it has really good support here and great support of all the implants. Because, as I mentioned, I don't want my implants moving after I place them, because I put them where I want them to go in the correct spot. So I like them to be supported, and that OG Bra's got really, really good support. And then you're going to use scar system 3 weeks later because you want to get the best scars. At 3 weeks after surgery, it's okay to do light exercise. And then at 6 weeks, you can do regular exercise. Okay? I'm going to skip some of this stuff just for brevity. And I'm going to skip ahead. I'll show you a few results. Everyone wants to see before and afters. I really want to just talk about how good these Motiva implants are and why I love this 6th generation. But let's take a look at some before and afters, just so you get an idea of what typically, if we're looking at creating a pocket and creating an implant to match the pocket to achieve fullness, cleavage, roundness, prettiness, upper pull fullness. This is basically what you end up with. Up above are her pre-op photos. Down below are her post-op photos. There's more fullness, and the breasts look very pretty. Is the different patient showing, and this is why it's sometimes hard to do this on social media compared to in my office where we don't have to have these little dots everywhere. But you can see implants can make a remarkable difference. The operation takes about an hour, and I always say there's really nothing that you can do, perhaps other than LASIK eye surgery, in such a short period of time that can have such a dramatic effect on your shape and your life and everything else. I won't even go into all the studies. I always hate when plastic surgeons say, oh, this is going to get your confidence back. It sounds so cheesy, but it is so true. It sounds terrible. We're like, oh, come have surgery with us. That's how we make our living, and so you can get your confidence. It sounds like we're just selling things. But if you actually I would love if I could just have a camera with me for a whole day and just see patients coming back from having surgery. And if we looked at, just the breast augmentation population, it's an incredibly happy group of patients. And they do have more confidence and they do feel better. And it's amazing what this little device can actually do. And I've seen it time and time and time again. I just feel like we sound really kind of, self-serving when we talk about it, but it's really true. Okay, we looked at this, meaning that your implant is not your friend's implant is not your implant size. And the reality is that we're not really looking at implants and results in patient in these kind of artificial poses. We're usually looking in real life, and that's usually with clothes. And so it's amazing some of the things that can happen. You don't even know actually that the person in the white, that she actually had a lift. You can't tell with clothes. You can have patients, and this is always interesting to me. This speaks a little bit to the confidence. Typically, you'll see patients before surgery, and you can see them, they're kind of a little bit sort of down. And after surgery, they tend to be like this, more confident. They're not very happy. They're a little shy. They're embarrassed. They're not feeling very confident. And then afterwards. And it's something. I've seen that in so many post-op photos over time. And it's amazing what things can happen. And sometimes patients will say to me, oh, that's not the same patient. Well, it actually is. And you can play what's called the mole game. And if we look here, I don't know if you can see this. See, there's 2 moles here. And there's 2 moles here. That's the same person. There's a mole here. Look above. There's a mole right there. Now look at this mole. This is really interesting. There's a mole here. Do you see me over here? I'm over here in the before photo. There's a mole here. There's a mole here. And now you see a mole here. But where did the other mole go? It's right there. It's been moved. See how that little skin has come up from her pre-op to her post-op. So it's the same patient, because it's unlikely you're going to have 2 different people with the exact same moles. Anyway, it's just, it's wonderful. I could show you sort of picture after picture after picture. And you just get a nice, pretty breast, and it just has such an impact on patients. Okay, let me finish up with taking a few more questions because we're at our limit and we're getting close to my bedtime, which is 10 o'clock. So let us take a look here. Natalie Clark asked, hey doc, I'm 46, looking to get a lift with implants. I have sleep apnea. Can you talk about this? Is it better to do it in the hospital? It depends on your degree of sleep apnea. But in general, patients having sleep apnea, it is better to have them monitored overnight in the hospital. We worry about patients not being monitored properly. Now, because you can get a little bit sleepy and taking narcotics can be an issue. If you are super responsible, if you have a really responsible caregiver, if everyone knows how to use a CPAP machine and you're compliant with that and you don't just keep it beside your bed and never use it, and we talk about it and we can dose the narcotics properly, then yes, I think it is safe and we can do it, and I do it in certain situations. And I work very closely with Frankie, who's my CRNA at that time, keep people in recovery a little bit longer. We take some precautions. If it is significant sleep apnea, because there's different degrees, then yes, that would be better to be staying in an inpatient setting where you're observed. If it's mild and very compliant, then we can handle that as an outpatient. Is recovery similar in mastopexy augmentation? Great question. I love it. You guys give good questions. I love it. In fact, aren't we doing that soon? I'm going to be doing just like a question session, not sort of a prepared talk, where I'm just answering questions. And so I look forward to it because they're really good questions. You guys have asked really good questions tonight, and I appreciate it. All right, let me just remember what the question was. Is recovery similar in mastopexy augmentation? Ms. Sarton. So yeah, it's about the same. a breast augmentation recovery and a breast lift with implant surgery, the recovery is about the same. It doesn't make intuitive sense because you're like, well, you're just putting an implant in, and two, you're doing a whole lift. But the discomfort from a breast augmentation comes from the implant, not the incisions. And so the same thing is happening in both an implant or an implant with a lift, and the pain really is coming from the implant, and it's not coming from the incisions, although you might think, wow, with all these incisions it's going to be more painful, and it's really not. So about the same recovery, aug and masto-aug. Is there a benefit to incision point being in the armpit? Heart Shauna. My wife's name is Shauna. Is there a benefit to incision being in the armpit? Well, you're bringing up a very interesting topic. The answer to that, I would say, is no, and most breast augmentations do not get done like that anymore, because when you're operating kind of remotely, you're making an incision in the armpit, and now you're trying to operate all the way down here. And what I kept talking about tonight, a lot of times, we're talking about tuberous breast, talking about double bubble, talking about implant malposition. We're always talking about the fold. And so I think it's very difficult to do a good job managing the fold when you're operating from up here. So I don't like that operation. Most surgeons don't do it. There are some surgeons in the country that do it, and they're good at it. If that's what you really want to do, find one of those surgeons to do that. But to me, it's fraught with more bleeding, more implant malposition, and more problems. So I don't do that operation. All right. Hope you have 600 on me. Okay. Well, maybe if you have a bigger breast and soft tissue and you want big breasts, it's possible. Vivon, I'm trying to understand. I don't totally understand your question. You got a 415cc breast augmentation, but I didn't like how they looked. They looked drooping. The doctor did it because of the nipple, because they were. I think what you're saying is, if I understand this, that perhaps you had some drooping before surgery, and then you had a big implant. Well, 415, we consider anything over 400 to be a big implant. I mean, there's bigger implants, certainly. But, 415 is reasonably sized implant, and perhaps you got that implant because you were hoping that it would lift the breast or change the position of the nipple, and now you find out that it doesn't work that way. The implant doesn't lift the breast. It's not going to raise everything up. So if you need a lift, then you need a lift. Now, if you've already had an augmentation, then we can just do a lift, providing the pocket and the implant are all in good position. So that would be, sometimes I do that with an implant exchange. Somebody wants to be bigger, or if they want to be smaller, I'll remove the implant, change the pocket, and then I'll do a lift. I usually put in internal bra in, and quite often I do a little bit of fat grafting with that operation as well. Blanca, thank you so much for thanking me. I appreciate that. The main thing is I want people to be educated, understand, and it's not just for your benefit. It's also for my benefit. That's 100% true, that it helps me. Because can you imagine if you have somebody that comes in and they have no idea about a breast implant, and now I'm saying, hey, these are the 6th generation implants with a nano texture, different shell technology, more cohesive, and a more upper pole fullness. They're gonna be like, what? And I'm like, oh, I use a sizer. This is a textured implant. This is an anatomic implant. It's a round implant. How are you going to get all that information in a short period of time? You're not. You're nervous. You're naked. It's too hard. It literally is too hard to do a full, comprehensive consultation to know everything that you should know in just meeting a surgeon. And so you have to do your work beforehand. The problem is there's a lot of misinformation out there. So I like to tell patients this information, because when patients come in and have a consultation, we have a higher level conversation. We're not going over the rudimentary things, the basic things. We are just clarifying things the patient didn't understand. Maybe somebody's like, wow, your whole explanation of under the muscle, under the fascia, under the breast, I didn't follow that, it's confusing. Okay, but at least you've run through it, you've heard it, and now we can clarify a few things rather than having to start at scratch and explain what fascia is and all that stuff. So it not only is for your benefit, it's for my benefit. It makes the patient better informed, and then we can have a much better conversation, and we can really get you to the point where you're like, okay, I feel like now you know what you need to know, and you're ready. So, KOE asked me, how do I do consultations with virtual patients? Okay, what I used to do is I used to do a virtual consultation. I'd be on my computer, but it didn't really work very well because when I examine a patient, I'm like, don't move. They move a little bit. I'm like, stand still. So I like my patients to be really still when I'm examining them. And it's impossible to get that in a virtual because there's movement and there's different camera angles, and I can't tell what is going on or what's what. So I'll do virtual consultations for patients that are out of state. I have quite a few patients that are out of state or even from out of country, and they can come in, but I like to view their photos first. So just a still photo. So it's not just like these photos, head on and lateral, not with shoulders like this, not with one arm up, not a selfie, but just straight up and straight to the side. And then I can look and I can see exactly what's going on, and then I can make a recommendation based on that. So I don't do a virtual, but I look at photos, and then I can tell, okay, you'd be a candidate for this, this, or this, or maybe a candidate for this. And if I don't know, then I'll say, I don't know, I need to see you in person. So I do that, and I do that every day. Okay, let's say 3 more questions, and we will wrap it up for tonight. It was kind of funny, by the way, on that video that I posted with that little chip coming out. Some of the comments were really funny. If you have funny comments, you want to leave them on my Instagram, leave them. I mean, I love them. And it was the tracking one. Someone's like, if you're going to be paying for someone's implants, you need to know where those boobs are at. I mean, that's hilarious stuff. So, never hesitate. I don't mind. Want to take shots at me? Have at it. I love it. I'll take them. Okay. Nicole P. said, do you recommend antibiotics before dental work with implants to avoid bacteria causing capsular contracture? Used to. We don't necessarily anymore. There's not good data. I just looked at it again not that long ago, what the recommendations were. We don't have great data for it. There's no study that's ever been done to show someone that had dental work and then went on to have capsular contracture or they didn't. There's no study to prove it. Intuitively, it makes sense. So patients will use prophylactics. Usually their family doctor or their dentist will prescribe them an antibiotic that they take beforehand. So I don't think it's gonna necessarily hurt. It's just that we don't have a great answer for that, and we used to really be emphatic about it. I just don't know that it's really true anymore, but probably it's not going to hurt to do it. Oh my goodness, Merle L is asking me, have 17-year saline implants under the muscle needing an exchange? Can I put the new implants under the fascia? Ooh, that's a super good question. I wouldn't, because I don't think you need to. Then you already have one plane opened up underneath the muscle, and that's a good location for an implant. So I don't think you need to go underneath the fascia and now open up another plane, and you can create problems where the implant can now decide which pocket it wants to enter. So you'd have to close one pocket and open another. And I don't think you'd need to go through that. If you already have a nice pocket, all I would do is tighten your pocket, perhaps use a little bit of mesh if it's really loose. If you have a saline implant, sometimes that can happen over time where that saline will wear on the breast. So I need to sometimes use a piece of mesh in there. But I would just stay with the submuscular pocket and put new implants in and just adjust the pocket. There's a lot of things we can do inside the pocket. It's really amazing. You can actually get quite creative when you're in there. I'm not going to go into that. Those are more technical things that, surgeons talk to each other about, and it's kind of cool. But there's a lot of things we can do to tighten the pocket, and a lot of little different techniques that we can do. So I would just stay with your pocket. Okay, let's see. Let's take. I'm gonna do one more question. They all come with a microchip. Can you get an implant without it? So no, they don't all come with a microchip, and it's an option in this new implant. And the microchip only has serial number and implant information like the size, the manufacturer, the style, the profile, all that information. But they don't come in the implants. They only come in this one. Here's one, for example. There's no chip, and this one has a chip. But the only reason they have a chip is that patient, and it's really only used in Europe, but the only reason is because the person wanted it and they ordered it. I think it takes 6 weeks in advance. You have to order it. I don't think it's really necessary because you're going to get that information. If you keep that in your wallet, then you don't really need anything else. Or take a photo of it and keep it on your phone. You'll have it for the rest of your life. So they don't come with chips inside them, and no one is tracking you with this. Natalie, I got your follow-up question. That really not much is going to change about my answer. And if you really wanted to sort of pursue that with me, then I would want to go through some medical clearance, talk to your pulmonologist, get a letter from them, any other medical comorbidities, if there's obesity, if there's any heart problems. So there's a lot more to it, but we would go through that, and I would look at you and look at all your information and look at your doctor's recommendations and then make the decision based on that. Okay, I think that's going to be it. Thank you very much. I really enjoyed it. I loved the questions. I thought they were really, really good and super helpful. And if you... Oh, I got to give the guide. What am I talking about? Let's see. I'm going to go down. I'm going to pass through some of these photos. And here it is. Here is the guide. And this is good. This is a top 7 things you should know before having getting breast implants. It's a QR code. Scan that. If you're on your phone watching it, just go to the description of the video, and there will be a QR code there, and you can get the guide for free. And it has everything I covered in here today, so you'll know all about the different types of implants, everything else. So that's it. Thank you again. I appreciate you watching, and I appreciate all your questions. And I look forward to doing it in another 2 or 3 weeks. And I want to talk about fat grafting to the breast, because that's a really interesting subject too. And fat grafting works really well with implants as well. So until that time, have a good evening, and I will see you. Thank you. Hey, it's Dr. William. Grab your markers.
Have you ever wondered why
Life will through the key area, round, fill in the hip, blend that into the leg. I've got my pen and paper out today. I want to talk about... Okay. Yeah, okay, relax.
Welcome to my YouTube channel.